So good morning. My name is Aaliyah Runyon. I'm the Education Research Fellow for the American Medical Student Association. And actually, you kind of, Dr. Main, you kind of took my question a little bit, but I want to expand on the idea of patient safety as an overarching goal to deal with the kind of dissonance, the upstream dissonance that we were talking about before, and how maybe this is a way to connect the education piece, because now patient safety is almost required in most medical schools, and also I'm assuming in most other professional schools. And then as a shared goal for professionals in practice, this is obviously a very critical skill set. It's a very measurable tool, as you know, patient outcomes are very important for cost, for our kind of like our general ethical principles, and also for just betterment of healthcare. So I'm wondering if we could expand a little bit on that, and as a way to like connect the two and kind of calm the dissonance a bit. So that's my question.
I'll just preface that before I invite Jody or Eric to make a comment, and Kathy, maybe you too, based on the work that's been done. I do think patient safety allows us to create Switzerland to a certain extent in our work, so that, because who can argue against it, right? But I just ask you to reflect on how patient safety is involved in any of these projects that you've discussed.
I'll start. I think you've fundamentally hit the most important issue. I don't see patient care and education as separate. And I think that's been a really unfortunate part of our history, that you kind of do clinical care over here to get your experience and you educate somewhere else. And that's been really flawed. I can't speak as much for the professions, but that's been one of the fundamental challenges in medical education, is that somehow education and the kind of clinical experience aren't necessarily overlapping, and yet they should be one and the same. So if you're going to create a patient-centered healthcare system, you have to have trainees experiencing what patient-centered care looks like in order to effectively learn it. We have some evidence that now shows that if you don't, you go out and you don't do as well as a practitioner, and that imprinting lasts a long time, you know, to some degree. And that, obviously, within patient-centered, it's the safety. You can take the 6 IOM aims, or you can take the triple aim, whatever you want to use as your grounding. I think that's absolutely, and you would hope that if you can use the focus of what's in front of you, the patient, but not only the patient, but the community in which you're working as your touchstone to drive your education. Obviously, interprofessional work flows, you know, from that. You can't do patient-centered care without it. So I think that's really important. And I think your concept of beginning to look more and more at outcomes is also important. One of the things we found, again, in the study that Amy and Ben did, very little was actually related to patient outcomes. Now, Lucinda points out that's changing. There is some data, but we need to do a lot more there. And, you know, the data that's there is actually quite encouraging. You know, better teamwork, better interprofessional work leads to better outcomes. We know that link. It's just a matter of how do we make sure that we can most effectively have people learn it, and most of it's going to have to be done by doing. I mean, it's not something you can do effectively and completely in a lab. So, I mean, that's really important. So I appreciate your comments.
Jody, just turn your microphone on.
One of the other things is I was just looking at the instrument, and there are several items that fall under, one under ethics and one under accountability, but they relate to errors and near misses and the discussion about how you deal with those in an interprofessional nature. So it actually takes it beyond a profession-specific safety issue to, you all have accountability and safety issues around a team, and how you negotiate and manage those situations really brings it to a discussion around safety, but also ethics. And what are the ethical issues around not addressing those errors or turning the cheek? And I think that's a conversation that doesn't happen. So people and students all the time, or interns, say, I saw them do, I've read many of the medical narratives, and they identify, but what happens is they're afraid to disclose because they have a fear about repercussion. If we're having safety issues and we're afraid of repercussion, what does that say for our outcome with patients if we're not willing to address them and sort of acknowledge them? So there are 2 items in here, and one of the best things will be for us not only how they answer the psychometrics, but comparing the preceptor to the students. What are their different perceptions in terms of self-assessment, how that looks, because that's also part of the study of the learner does this, or the intern, as well as the supervisor.
Kathy, did you have anything you wanted to say?
Well, I'm very involved in the upcoming IPEC Summit focused on quality and safety. It's going to occur next Monday through Wednesday. We're so excited about it. But I think our IPEC CEOs guided us in the exact right direction, that if you're in practice, you know that sentinel events and problems with patient care are usually due to lack of teamwork and collaboration and fragmentation of care. So this is going to be a wonderful conference. Nursing, I have to put a plug in for them. We have been leaders in this with the Quality and Safety Education for Nursing movement. That focuses on 6 core competencies that the IOM identified in 2003. So we have 172 people on the wait list and more institutes to come, and we invite all of you to get involved.
And just a shout out to students, remembering that the Clarion competition originated at University of Minnesota, and it is a team-based competition focused on a group working through an era or an issue of safety, and it's now extended to a national platform. I'm going to call on you, and then Patricia.
Oh, thank you very much. Great presentations. My name is Sally Oken. I'm from Patients Like Me. Jody, I'm particularly interested in whether or not there was any public or patient involvement in the iterative process that you went through in developing the IP, the collaborative itself. And if not, why? And if so, I'd love to hear more about it.
Well, interestingly, you know, we took this, the forums had all the different health professions, but some of the health professionals have been patients, so they were able to talk about both of those. We also went to Australia, and we did one in an international forum, and in that one it was very interesting because Israel, the Philippines, Canada, Australia, a number of other health professions were in the table, as well as some individuals who were patient-oriented, and that was a very interesting discussion. We even had Ron Epstein was in our audience, and Maxine Papadakis was in the audience, which intimidated you-know-what about us, but when they were sitting in the audience. But they asked some interesting questions about the potential, the possibilities, and if this, in fact, could be more global, what would it do to how professionals interact across the globe? Most of them found some interesting relevance, and I had a number of people come up who were both health professions and a couple of patients who said, if you could get the environment to look like this, our care would be different. If they really would, as a group, acknowledge, respect, talk the same language. I go to 3 different health professions, and I think they're talking about the same problem, but I'm not always sure they're talking about the same problem based on what they say about it. So there were a number of things that they began to say this would be a different environment if practice looked like this. I couldn't tell them that it would happen. I said, that's what we're assessing.
One thing I'm sort of trying to drive at here is this is a very packed concept. It's packed for all of us to just get our heads around. So I'm trying to sort of come up with the PSA moment for the public. What does this mean to the public? How do we start to get a message about this that resonates with them and matters to them? So I think every time we don't take the opportunity to engage and ask that question when you're developing these things, what would make this matter to you, and how can this be communicated in ways that you could not only understand but appreciate and then disseminate? So I think we just constantly have to be asking ourselves about that, because to come to the public or the society at large with what we've got here, this word, all of this packed in, is going to take a lot of messaging. So.
It's been an overwhelming concept for all of us to try to grapple with. That's why it took us 2 years to get to a definition. We'd go down a road and turn. But you posed something very interesting. I wonder if this tool, once validated, hopefully, if the patient were actually asked, did the team do this with you? Whether, in turning on the other side, whether they would actually be able to respond to that. Because we tried to stay away from jargon in the tool itself. So when the preceptors did that cognitive interview, if the words didn't mean the same thing to a speech language pathologist and a physician, we edited whatever. So it'd be curious after that to say, I'd like the answer just one in each category. When you met with the team, did any of the following happen? And that would tell us, is it happening in the environment or not?
Probably overwhelming, but to the extent you could, it would be awesome to interact with a group like yours before it actually goes live for prime time. Tricia, and then.
I don't know if you can hear me. Given the conversations we've had around health versus disease-oriented care, I'm just wondering how, I agree with the patient safety concept and improvement science and all of that, but I think as we shift from a disease dominant to hopefully a health dominant as where business and other groups are going. I'm just wondering how much discussion and how much is in the instrument that really focuses on health, which might push us away from the word patient to person. And I'm just curious because it tends to feel to me like we're still talking to ourselves about the same kind of thing when the person is in our setting versus where we know it's shifting, which is to home and to many other spaces.
Yeah, I think it's a really important, point that you're making. Obviously these kind of tools are going to be useful when you actually contact the healthcare system. But, like you said, part of the triple aim is really focused more on health, and wellness. I mean, obviously that's what we want, and that's where we hope most of the folks spend the majority of their time, right? It's not in the healthcare system. I'm not sure, these kind of tools are going to get at that real well right now because they tend to be based on an interaction. So I think it's really an important piece of work to think about. The other caveat, and again, I work for certification boards. I'm a big fan of psychometrics, but psychometrics has its limits. And I think sometimes we get stuck in trying to create these kind of tools without simply engaging in conversation. So I'm reflecting on your comment where frankly the conversations and words are going to be much more useful than any box I can check. And I think that's actually where we're beginning to see even assessment go in general. You're seeing a shift away from kind of the psychometric only paradigm and beginning to use more qualitative techniques to actually assess both individual, team, and institutional competence. Some very nice work by Kees van der Vleuten and Maastricht, kind of getting people to shift. Beth Bernabé, who's here and who will be running one of the workshops group today, is looking at professionalism as a conversation and using a tool that's more about reacting to a vignette about how you might handle it and why than any particular right answer. I think that's kind of where we're going, and it gets a little bit what Fred talked about, right? It evolves. It's a verb. It is not something that's a static concept. So I think this is very much the same thing. How people define health also varies greatly from person to person. One person's health is another person's disability. There's lots of work on that. So I think that's an area that really needs a lot of attention, and I appreciate you bringing it up.
I'm going to go in the middle, and then to Maddie and Jordan, and I'm going to go around the room. And Warren, you're probably going to be the last after George. Just guessing.
Thank you, Jody, for your very interesting talk. I really enjoyed that. My name is Marike. I'm from the Stellenbosch University in Cape Town, South Africa. I'm very happy to hear that the problems you experience, we also experience, or the other way around, I guess. I just want to ask you maybe to comment on something. Every year in our 5th year, we have an ethics block for the medical students in which they reflect on experience, and every year it's the same thing. They come out with some issues they haven't discussed before in terms of their experience in the services with health professions in the services. So we train them in the services, and we as a university don't really have jurisdiction about that staff. So then we try and facilitate a discussion, but then what happens, it's almost, it's as the students are angry with us as management that we are not empowered actually to make these things go away, so that next time when the next year comes that there won't be these things in the health services. I guess my question is really, how do we deal with being realistic with what we have in our context without say it's nothing and it will go away, especially in terms of the interprofessional teams, because I'm talking about medical students, but they often talk about professionalism from nurses and other people in the services. And then it becomes almost a turf issue. Yeah, it's the nurses, it's the doctors.
Do you have a thought? Turn on.
You're raising one of the questions, actually, we had to deal with in even trying to design the study. So to help you a little bit, the programs that we're using have to have IPE in their institution, and they have to send the intern to a practice that has collaborative practice. Because we already know there's a dissonance between what may be taught in the institution and what they see in clinical practice, or vice versa. The clinical practice has a collaborative entity and they practice that way, but in the education system, they haven't done that. So one of the things we're aware of is some of the preceptors on some of these items said, I could observe it, but we don't do it here. So we know that there's going to be some items that are going to be not observed right now because it's not happening. This is sort of a transformational type of culture. I think one of the bigger things for me is how do the communities talk to one another about what it is they value and how they're doing it. So I don't know that the practice community knows how education is teaching that concept and how they apply it and in what kind of scenarios. And I don't know that you know how are they translating that in clinical practice. And if those two communities could get together differently about a shared common theme, it might help. One of the things that happened, a couple of the items disappeared from this tool because the clinician said, we would not do that in practice. They would have to do that in education. So they already sort of segregated and said, our environment wouldn't do that. They should come to us from the institution having this before that. So this should come out of this tool and go into education. And that told me already there's a schism. There's lines between who does what and stereotyping and roles rather than we're creating the best practitioner who serves society and the patients to provide the best care. It's your area and my area. So that's one of the things we picked up just as a sidebar that didn't actually make us feel better.
Great. Maddie?
First, I want to thank the Planning Committee for bringing the whole issue of values and shared values to the forefront. I think we got off to a great start this morning, and this is very much at the heart of what we need to work out together. Having said that, I wanted to go back to some slides that Jody shared with us. And in particular, the slide that's labeled IPP and quality care, where the first circle shows professionalism as the larger circle and interprofessional professionalism as the smaller circle. And I would like to suggest that those need to be reversed. That as long as you contain interprofessional professionalism within the larger circle of professionalism, we continue to look through the lens of our own individually defined professionalism ideas. If we start with the notion that we have shared values, and this is one of the reasons why in the IPEC report we put values as the first core competency for interprofessional collaborative practice. If you put that circle, the larger one, as interprofessional professionalism, and you put smaller circles in a larger circle that represent our individual definitions of professionalism, it pushes the idea that we, beyond our individual professionalism discussions, have a set of shared values. Then we begin to look at how those narrower definitions interact with the larger arena of shared values. And then if you go to the slide that says more examples of IPA behaviors, and the second point is ethics, when you make that shift, you begin to realize that when we move to a conversation about interprofessional professionalism, we not only share some ideas about common behaviors embedded in our professional perspectives, but we generate tensions and new ethical problems that we need to sort out with each other. And let me just give you two examples that have come up in the dialogues I've had with people
in the
over
interest
years.
of time, could we let Jody respond because we have 4 other people who want to
Okay,
speak?
can I just give the two examples?
Very,
One
very quickly,
is
please.
one is confidentiality, and the second one is how we understand our relationship to patients and families. And if we begin to think about that, we get back to the patient-family issues.
Thank you. Thank you.
I think, first of all, that's fabulous because I think we were thinking smaller. It's a very new notion and we need to be down here and the professionalism everybody knows. But maybe over time, as this is an active, evolving process, maybe in fact they do get flipped. maybe as more people embrace the concept of what is an IPP and that it's possible to hold your own individual professionalism while entertaining this, I'd be happy to modify in our article and to do a follow-up in our next one when we write the report and maybe rethink the model that maybe interprofessional professionalism is a different notion where we start and the other pieces, values, ethics, are a subset in the professionalism. So I think that's great.
Great. Jordan?
Thank you. I'm going to build on the comment I made after Fred's talk. And from my point of view, ethics and values and these codes are all exceedingly important, but professionalism is, if we're going to recognize it, is our behaviors. They're individual behaviors, they're team behaviors, or they're institutional behaviors. And I think the work that you're doing is fabulous. And I think it's very, very important to identify those behaviors so that we can measure them, we can evaluate them over time, we can role model them, we can do all the things we need to do in order to ensure that they are incorporated into all the professionals and non-professions that are involved in patient care. So let's stipulate that we can identify those behaviors and do all those things. What troubles me is the notion that these individuals and teams and institutions are going to be operating in a real world context where there are enormous threats to maintaining the credibility or maintaining those behaviors in ways that are producing the outcomes of quality, patient safety, improvement, all the things that I'm sure we can measure and over time will document that these things do translate into better patient outcomes. But in the context of the threats to professionalism, all of the changing healthcare system, the changing financing system, the changing organizations that are going to impact on individuals and teams and institutions, it seems to me that it's exceedingly important that those individuals and teams have a resiliency to maintain their commitment. So to my mind, what that means is we got to be sure we select the right people to populate those teams. We identify the ways in which we can reinforce the passion that people have to behave professionally. Without that ingredient of passionate commitment to these values, the behaviors can be skin deep. I mean, they can fall by the wayside as soon as there are major self-interest threats that emerge, which they undoubtedly will, and increasingly so, I believe, in this changing healthcare system. So I think we got to spend some time thinking about what it is that sustains the professional behavior. Once we identify what they are, that's not sufficient in my view. We've got to figure out why people do it and why they maintain their commitment to doing it in the face of these very adverse circumstances that they're embedded in.
I can't agree more. And actually, one of the professions said, could you, once the instrument's done, identify or find ways that you could predict upon admission those applicants who would embody IPP at the other end? And the specific profession that has trouble with this said, once the instrument's done, that's our next challenge is get the right questions to ask, whatever the broad base are, that predict the ability of people to have that. And that's a huge order, but that's what they would like to see.
Let me congratulate you, I think, on a brilliant presentation, both in terms of presentation and content. But do you assume a certain homogeneity of the professions? Have you ever thought in your original formulation of this that there is also intra-professional dissonance? And how do you deal with the intra-professional dissonance and intra-professional professionalism?
Oh, God.
Just say yes.
You got an answer for that?
It's a reality.
That's the next decade's work.
You know, you know.
Absolutely.
Oh, absolutely. And I know that we all experience that internally with our own professions. And actually, I often wonder, was it easier to have the discussion with other professions and some of the navel gazing that occurs within your own profession and where it's sort of self-destructive. So it was, We have, I mean, I'll admit physical therapy has that in a number of ways. And this actually gets you out of a box. If you start talking differently about the behaviors, some of the items that the group came up with, we all sort of said, it's absolutely the right behavior. And then we groaned and said, but we don't think it's there yet. How do we move people from a place where we won't even report within our profession to now saying, I'm identifying medical errors that are not mine, but I own them just as much because it's for the patient? I think that's a huge undertaking.
Great. So we have 2 questions in 2 minutes. George and then Warren.
Great presentation, Jody, and great work. Both you and Eric have said in your comments that to succeed at this, we have to more and more think of the educational world and the practice world as one. That's a tall order. That was the subject of the last Macy conference, co-chaired by Malcolm and Mary Naylor, and several people in this room participated. Recommendations were made across 5 domains to try to accomplish this. I'm interested, Jody, in your work with this group over the last decade. How much talk went into actually accomplishing that? Did any good ideas come up about how to do it? And Eric, in your measurement review, have you come across anybody who's actually getting at measuring that linkage, that synergy between education and practice as being one of the markers for success?
Well, I'm going to take your question back to the IPC. That's a collaborative question. That's not mine. And we actually meet in August, and maybe we can begin to identify how do you deal with that concept of interprofessionality, or the bridge between education and practice, and interprofessional education practice. And maybe they can come up with, because we have in our group both educators and practitioners who sit on the group. So we have that, and association, we have all 3 within the group who can give us maybe some ideas about how would you begin to do that?
Just real quickly, George, most of that work has been done at looking at interprofessional care, not necessarily education. So unfortunately, not a whole lot as it translates into the practice space. There is some interesting pilots going on in student-run clinics that combine the professions. So Dan Duffy's work, for example, in Tulsa has a student-run clinic that has pharmacy, nursing, and medical students all working together to improve the care, and they're seeing improved care for the patients. That hasn't been written up yet. I think ironically, some of the newer medical schools are the ones that are being the most innovative because they can. They're not stuck with kind of where they've been, and so they're doing some of that work, but there's not a lot published on it yet.
Sure, and Warren?
Thank you very much. The question I have has to do with the time course of this. A lot of the way we're talking about is we do assessments that are stop action snapshots, but to what extent in the deliberations of the IPC is there a concept of lifelong, and is the vision that you have ongoing continuous assessments as we go forward that is linked to licensure and accreditation and all those good things?
Oh, right now when it's being tested, it's a no threat. It's not a limiting somebody to progress in the curriculum, whatever the profession, because we can't. And that came up that it's low stakes. But at some point, depending on how it's used, we recognize that if it's introduced in a curriculum and things are done, it could become moderately higher stakes of some sort. The other side of it is we're doing a moment in time, but it would be something that would be done throughout the internship. And the question came up in our group, do these behaviors change with more experience? We're using these under the guise of a new grad coming in, whatever, but how might they change 10 years, 20 years, 30 years out? And one of the questions was, well, if we're not demonstrating it now, how does it change when we don't have it yet? So there were some that change and some that we need to get into the culture. But that would be the other end of the continuum. So the admissions, and then 20 years out, how do you look different around that? How do you model it differently? How do you mentor?
And Eric, the final word.
Yeah, just real quickly, so Warren, it's a really important point. The research to date, looking at any sort of multi-source instrument, shows that you really need to use it for formative purposes. Every time you try to use it for high-stakes purposes, you change the nature of how people use the tool, and you reduce its utility. That much we know so far. The second thing we're learning, I'd really recommend Joan Sargent's work from Dalhousie, is that if you don't look at these type of instruments with a peer or a coach, it also has less effectiveness. Looking at this data in isolation, whoever you are, doesn't matter what professional, it reduces the effectiveness because you need somebody to help you interpret this type of data. It's very behaviorally and culturally and socially based. So those are two things I would just kind of add to that we kind of know is really important.
Help me thank Jody and Eric.